All right. So I'd like now to welcome to the stage Dr. Laura Schummers. Dr. Schummers is a reproductive epidemiologist and health policy researcher. She completed her doctorate in epidemiology at the Harvard School of Public Health in 2018 and her postdoc fellowship with the BC Ministry of Health and the Department of Family Practice at UBC in 2021. She joined the Collaborative for Outcomes Research and Evaluation in UBC's Faculty of Pharmaceutical Sciences as an assistant professor of health outcomes in 2022, where she leads the Reproductive Population Health Data Research Team. She serves as the Director of Epidemiology with the Contraception and Abortion Research Team in collaboration with clinicians, policymakers, and patients. Dr. Schummers conducts epidemiologic and health policy research to examine reproductive health, service access, and population health outcomes. She is joined by Victoria Greene. Victoria is a recent UVic graduate with a BSc combined honors in biology and psychology. Since May 2024, she has worked with the UBC Reproductive Population Health Data Research Team as a patient partner, helping to evaluate the effects of BC's equity, and is also a member of the Access BC campaign team. Whoops, I missed a sentence there. She's passionate about reproductive contraception coverage and accessible pain management for intrauterine device insertions across Canada. Whew, that's a mouthful. Anyway, I welcome you both to the stage. I'm going to lower this because I realized Tony was right before and I'm on my tiptoes, so.
I'll just bring that right down to the podium there. Okay, thanks so much for the introduction, for having us today. It's really great to go right after the legacy airway health because I think it shows really the contrast in our clinical areas and how patient partnership might look quite different in something like asthma or COPD research compared with something like reproductive health research. And that's really largely what I wanted to talk about in terms of both the importance and as well as some of the challenges in real patient engagement in reproductive health. So, why are patient partners important in reproductive health research? Well, I think all of us in this room probably agree that patient partnership is important and arguably essential for really all health research. We've had really a legacy of not having patient partnership embedded within our research programs. Reproductive health is really different. This is a very personal, very stigmatized clinical area. It's a place where the health system has mistreated a lot of people historically and continually, and that having patient voices from a range of perspectives is really one of the only solutions to move out of that to a place where reproductive health means that people have agency and choice about if, when, and how to reproduce, and that they can get the support they need to action that plan through the health system. And research, of course, is an essential tool for optimizing our clinical care as well as our health system and policy structures that support reproductive health. So one of the things that's been a real challenge is, unlike something like asthma or COPD, where someone is diagnosed, and oftentimes they then have that condition. It's part of their identity for the rest of their life. Yes, of course, sometimes people may outgrow asthma, childhood asthma, but in reproductive health, these are transient states. So for some number of years, people may not interact with reproductive health at all, in childhood, for example. And then through adolescence, a time with a lot of rapid change culturally and socially, physically, physiologically, suddenly reproductive health comes to the fore for many people. So the first thing that may come up is menstruation, and how does that work for at least people that are assigned female at birth or some intersex individuals with female reproductive organs. So that might be first. And then for many people who again have female sex organs and are interested in heterosexual sex, then it's contraception. And that is really where a lot of my focus will be. From contraception, then we get into pregnancy. So either avoiding pregnancy, managing an unintended pregnancy, or trying to conceive a pregnancy. And these are states that people move into and then out of throughout their life course. So people may use contraception, but not see themselves as, I am a contraception person. I'm a person with contraception. It's not as logical as I'm a person living with asthma or living with COPD. I'm a person living with an IUD is not really a term that we use. And then as people age, they change that into, now I'm a person struggling to conceive. So I went from being a person using an IUD to I'm a person who wants a child and I'm having a hard time conceiving. So now I'm an IVF patient. And then I'm a new parent, perhaps. And now the reproductive health journey becomes navigating pregnancy and decision-making in pregnancy, or parenthood, motherhood, again, for people, for many people in my research area. And then at the end of the day, we move into menopause, which is kind of the finale of reproductive health for people, again, with female reproductive sex organs. And so identifying, like, who is it that we need to be focusing on here for reproductive health, who is our patient population, is really a moving target. And that has been one of the things that's most interesting about this area and why patient engagement matters, but also makes it a lot harder to have sort of a clear community of, like, these are the people whose experiences are essential for reproductive health research in general. So that's really how I see the role as different from many other fields within health, also really important. So now I'm just going to talk a little bit about, like, how did I get to be up here talking about this today and why. And maybe this speaks a little bit to sort of exposure to researchers and, how do we generate a new cohort or generation of researchers who care about this. So I completed my doctorate in epidemiology. It was like methods, making sure, do you understand bias? Do you know how to mitigate bias or prevent bias? And data, I came out like, I know so much about epidemiology. I'm, like, ready to tackle the world. But I came from a place where this was very abstract, intellectual, sort of ivory tower research. And immediately moved into a postdoc that was a partnered kind of research arrangement, where it was mostly clinicians working with health policymakers and health system leaders to think about, like, how do we move from research findings to translate policy and practice change. And so I sort of was thrown into, now I'm a fresh graduate with a PhD ready to use these skills. How do I now blend that? I'm the only epidemiologist in the room. How do I blend that with actual impact for health policy and system leaders? That's really where we started. So as a postdoctoral fellow, I joined the contraception and abortion research team, which really has, it's a research team, but it also, beyond that, is really a partnership team, mostly with health policy and system leaders, researchers and clinicians. Patients have not generally been a main focus of that partnership. And they've been super successful in moving policy forward. So the project that I started to work on as a postdoctoral fellow was looking at the effect of a huge regulatory change for abortion care in Canada, which was first the introduction of the pill mifepristone, the abortion pill, in 2017. But more importantly, and where this partnership between researchers, clinicians, and health system and policy leaders succeeded, was the way that Canada introduced the medication abortion pill was globally unprecedented compared with any other country that uses this drug. So this drug had been around for about 25 years by the time it was finally approved by Health Canada, with a lot of restrictions. So, for example, unlike most medications that you just get a prescription from your physician and you go to any community pharmacy for dispensation, there were, like, rules. Like, you need to make sure that the physician is registered with the manufacturer of the medication as well as the pharmacist. Initially, physicians needed to directly dispense the medication, but we don't really have an infrastructure to make that happen for the most part. And so what that meant was that abortion care, even with the abortion pill, only occurred in really abortion-specific clinics, so specialist clinics. Now, when mifepristone was introduced in Canada, the goal was to improve access to abortion services. We'd had deplorable abortion access for a long time, to the point that the UN's Committee on the Elimination of Discrimination Against Women chastised Canada for doing a bad job of providing equitable access to abortion care as well as affordable contraception. So through a partnership with clinical leaders and health system and policy leaders, Canada did away with all of those regulations that were really, the consensus internationally was that they were not necessary, but were a way to remove agency from people's reproductive options, really based on ideology. So when the medication abortion pill became available with no restrictions beyond something like an antibiotic or antihypertensive in terms of prescribing and dispensing, then we had a lot of work to do to figure out, first of all, was this safe? So that was the global question. We're protecting women by making sure that abortion is only provided by specialist providers. We studied this, and that was in fact not the case. But in Canada, the goal wasn't to improve abortion safety. Abortion had always been safe and remained safe. That's what we found. The question in Canada was, did it succeed in improving access? And that's where moving from a partnership with health system leaders and policymakers became less important because we're not great at measuring access. So usually we measure access through things like use. And so we've done that. We've looked to see, did the abortion rate suddenly skyrocket when mifepristone was introduced, as some thought it might? And no, in fact, people only have abortions when they need them, not because it's easy to access in the health system. But again, that's not a great measure of access. We then wanted to look and see what about, geographic access, because that Canada, of course, struggles to provide equitable access based on geography for many health services, including abortion care. So we've studied that using very crude data. But honestly, none of these really answer the question of what is the patient experience of accessing abortion? And we're only looking at the people who manage to have an abortion. Sometimes people are not able to access the abortion care they need and then continue a pregnancy with long-term sequelae for their potentially socioeconomic or health outcomes. And that's something that we really need to understand more. We've done a couple other ways of looking at access. So that was really my postdoc, was focusing on these areas. And then through a very innovative program, I guess I sort of glossed over this, but as a postdoc, I was cross-appointed with the BC Ministry of Health through an innovative program, the Health System Impact Fellowship, which places researchers in between an academic and a health policy or system organization. And so that really created the opportunity for me to learn how to talk to policymakers, understand how to ask research questions, to give them the answers that they actually needed to influence policy and practice. And that was really life-changing. I absolutely loved it. I loved not just sitting there in the ivory tower of talking about epi methods, but really how can I translate between this is the method I know I need to use, but I don't really need to talk about that here. Here I need to make sure that our question is right and that we can translate results in a way that's useful to you, the people who will actually change policy and practice. So then toward the end of my fellowship, when we've been doing all of these sort of access measures and safety measures about abortion care, a few things happened. First, finally, after a decade of really the director of the contraception and abortion research team pushing for this, BC announced that prescription contraception would be available for free. It was announced in 2021. It took a little while before it actually happened, but that was a huge policy change that was coming. And then CIHR put out a new kind of grant opportunity, again, trying to scaffold sort of a cadre of people, of researchers who could be patient-oriented. So I applied for that as a postdoc, and that sort of supported me into this research program focused on patient-oriented research, which is what I brought with me as a new faculty member starting in 2022. And honestly, what I'm going to talk about next is sort of my struggle with Victoria and other patients on how do we actually do this now? We don't have that infrastructure that Legacy Airway has. It's been just, we're small potatoes. We're one PI, a little group trying to figure out how do we do this in a way that works. So here we are now where we looked at the effect of this universal no-cost contraception coverage. The last presentation referred to out-of-pocket costs. We know out-of-pocket costs matter a lot. It kind of isn't something we need even a patient partnership group to tell us, let's look what happens when we remove out-of-pocket costs. We know that's an important thing to do. So we've studied that. And what we're now working to do is with a reproductive population patient advisory committee, figure out how do we go next from use of contraception to contraception access. What does it mean to actually have equitable and unfettered access to the contraception that people want to use? And with that, I'm going to pass over to Victoria.
All right, so I guess I'll just go through a little bit of background on how I ended up working for the Patient Advisory Committee. So as Dr. Schummers mentioned, it's not really a straightforward path to becoming a patient in this population. It's not necessarily a direct diagnosis, and so I kind of had a bit of a winding path to get there. So obviously my first interaction with this space was not as a researcher, but as a patient, and specifically a teenager wanting to access contraception for the first time and not knowing really how to do this. I also grew up in a small rural community, and so I additionally faced the challenges that come with a rural community. It was mentioned in the previous presentation, but the issues with, I personally did not have a family doctor. And so this brought up a lot of questions for me on who should I be talking to about my concerns? What are my options? And then obviously I really didn't know a lot about private health insurance, which was important at the time as I was trying to access contraception before the subsidy was passed. And then again, the interaction in this space is a little bit transient, and so I didn't really think much about my challenges and what I faced accessing contraception again until university, when I came across the Access BC campaign through their social media. The Access BC campaign was really involved in advocating for the universal contraception subsidy here in BC. And I was first exposed to it through a series of posts explaining or describing patient experiences in the contraception world. And so looking through these, I really saw my own experience reflected in these, and this was sort of the first time that I realized that this was not an individual experience that I had experienced, and it wasn't only an issue in rural communities, but was part of a more broad pattern. And then I also, through working at Access BC over the last 3 years, have really come to realize that it's a combination of access to healthcare systems, public and social attitudes and stigma around contraception, and then also health policy that all interact to, I guess, affect access, really. And so it was through Access BC that I was first introduced to Dr. Schummers and the Patient Advisory Committee. And I felt like this was kind of a natural next step for me. And I also felt that I could bring an interesting perspective to the team, given that I had lived experience. I had lived experience in a rural setting. And then I also kind of, through my work with Access BC, had a larger understanding of the field. Next slide, please. Oh, it's me. Okay, so what have we done in this partnership so far? So as, again, Dr. Schummers mentioned, we are a small team. There's actually only 3 of us, but we meet quarterly, and Dr. Schummers will bring the team's most recent findings, and then we will discuss these findings in the context of our lived experience. And so one thing that we focus on, obviously, is identifying the barriers to access. And so, of course, we're talking about the major barriers, which is namely cost and financial barriers. But we also, I think one of the strengths of this group is that we are able to talk about kind of the nuanced and more logistical realities of contraception access that aren't reflected in the quantitative data often. And so just for one example, in the context of IUD access or intrauterine devices, we did again talk about cost because one IUD can cost anywhere between $400 to $500. But we also talked again about the realities of what does it look like to actually go and get an IUD. And so one of the things we talked about was the fact that when this prescription is dispensed by the pharmacy, you have to physically go, pick it up, and bring the device with you to your appointment, which might be the next week, but it's not, the physician doesn't receive the IUD. And so for me, this reality looked like my dad by accidentally picking it up from the pharmacy for me. And then IUDs come in a box, they're about a foot long. And I had to put this in my backpack and bring it with me to high school because my appointment was at lunchtime. And so for me, this was a somewhat embarrassing experience. But I was also really lucky that it was a safe experience. For a lot of individuals, this is not the case, especially for those facing stigma, family conflict, or even reproductive coercion. These everyday realities and logistics can actually turn into dangerous system-level barriers. And then part of our role is also helping to interpret trends. I'll cover this quite quickly, but we, in our most recent meeting, Dr. Schummers brought us some data that was showing that contraception use was actually declining despite the universal subsidy being passed. And so the 3 of us are all within a younger age demographic, and so not only are we contraception users, but also social media users. And so we kind of talked about this declining trend in the context of potentially the misinformation and mistrust that is prevalent in social media or on social media, especially within reproductive health care. And so could this trend on social media of influencers saying that contraception is not safe, could this be affecting the declining use that we see? Again, as Dr. Schummers mentioned, we are a small group and we're trying to navigate what is the best way to go about this advocacy group, advisory group. And so one of the things we need to focus on is obviously increased recruitment. But in this increased recruitment, we really need to make sure that we are recruiting a diverse population. Contraception obviously is affecting a really wide population across sex, gender, age, location, culture. So this is important. It's also important to recognize that contraception is not only used to prevent pregnancy, but can also be used in managing different gynecological conditions such as endometriosis or PCOS. So this will be important. Another thing that we're trying to navigate is finding the balance between how regular we have meetings and how they are structured. So I guess in terms of structure, again, it's really helpful that we have an open discussion that allows us to explore the nuances of lived experience. But we also need to find a way that this is structured enough that we can use these findings in a meaningful way. Not only in research goals, but also in grant proposals, in presentations like this. And then with how often we're having meetings, we've been finding that if meetings obviously are too close together, they become repetitive as we're talking about the same kind of topics. But if they are too spaced out, we also have been finding that we kind of will talk about the same general topics and kind of lose our momentum and not really be able to get into the meat of what we want to talk about. And therefore they kind of become repetitive, but in a different way. And then obviously in terms of expanding the role, as the research continues and moves in towards disseminating information, I think that the patient partners are at a really interesting position to be able to spread the information in a clear and accessible way to other patients, especially given the misinformation and mistrust that does often circulate in the reproductive health area. And so having patients being the ones that are spreading this information and are also kind of evaluating what information is being given to patients will be really important. Okay, and I'll pass it back to Dr. Schummers now.
I think we're at time, so why don't we can talk about bigger picture challenges in a more open discussion where we take questions. So thanks so much.
Yep, just applause. Victoria, I just want to acknowledge that was a great presentation, especially when it's a vulnerable space to be talking about, and the specific examples you gave were fantastic, and so thank you for that. Kent, over to you.
Yeah, I just wondered about, in your work, whether it's in contraceptive care specifically or, reproductive interventions of various kinds, have you worked with genetic counselors at all, and particularly in your patient advisory recruitment, have you reached out to people with physical disabilities that might be experiencing special challenges with access to care or certain kinds of care that are complicated by their disabilities?
That's a really great question, and that's something that, so first in terms of genetic counselors, we haven't yet. That's something that is really relevant for a very specific subset of the termination of pregnancy space, where people are often diagnosed or prenatally with potential or confirmed either structural or genetic anomaly, and then they go to see genetic counselors to sort of be informed about what the right choice is for them and their family. I actually am right now starting to work on a project led by a maternal fetal medicine clinician focused on that clinical area. For our previous mifepristone work, less so, because that tends to be, the abortions using the medication abortion pill tend to be before any awareness of those kinds of prenatal diagnoses occur. So that's something that I do hope will happen more over time. In terms of physical disability, group patient partners with physical disabilities, it's a great idea. It's something that there's a leader in reproductive health at U of T who's done quite a bit of work on contraception, reproductive health service access in general for people with physical disabilities, but we haven't yet merged that for this project. The contraception project, I'll say, we are kind of just now at steady state where we have our data access and we can be more agile in terms of answering questions as they arise from patient partners, where initially we were more in the, like, we're scrambling to answer the first did use change to tell the federal government if their policy intervention worked for them. And that took us really until like now. It was a couple months ago that we had that data kind of functional to do a broader set of questions. And that's a perfect example of the expansion for our patient advisory committee that we need to focus on. So thanks for asking that.
I see a question over here and a question in the back.
Perfect. Thank you so much. That was a really great presentation. I just have a question for Victoria. So I have the pleasure of working with Tony and our other patient partners at Legacy for Airway Health. And tagging on to the recruitment piece there, something that we are wanting to do is increase engagement with younger patient partners. So I'd love to hear a little bit more from you in terms of what keeps you motivated to continue to participate, and is anything done to help facilitate your engagement on this advisory committee?
Yeah, I think I come from a little bit of a different background, just having been involved with Access BC already, and kind of having been part of the advocacy work that supported the policy change. And so for me, part of the underlying motivation to stay part of the group is that I get to continue to see the results of that and see the actual real world effect of the policy change that I advocated for with Access BC. So that doesn't necessarily directly answer your question. Yeah, I don't know if we've necessarily done anything to keep patient engagement. I think the two, speaking for the two other girls that involved, they're not here, obviously, but they also come from kind of similar backgrounds where they were involved in the policy before. And so I don't know if this has necessarily been steps that we've taken, so I don't really have a good answer for you. But yeah, maybe Dr. Schummers has something.
Yeah, I mean, I guess in terms of continuing engagement, some of the logistics that were described in the last presentation, I think we've had the benefit of not needing to invent that wheel now. So like we have now, UBC has an easy process for remuneration, for example, or we don't need to explain how and why to do that. That's something that is just built in from the ground up, that of course everyone who's doing this work should be paid for their time if that works for their financial structure or otherwise. In terms of expanding that recruitment, we're kind of in one of the struggles, I think, is social media is often where people are telling us to go for recruitment. And we struggle a little bit with, like, that's also the space where all of this mis and disinformation happens. And is that really the right way to find sort of broad representation? And so to me, like, that kind of feels like a bit of the challenge, where it's been on me to try to learn a better way to do that, and I don't feel like I've been ultra successful at that from that standpoint yet. So I would welcome suggestions from those of you who have really succeeded for years of having that be the focal point of a research area.
You were at a great conference to get some good tips. Yes. I'm going to turn over to Dr. Kendall Hill.
Thank you very much. Excellent presentation. Thank you so much for both of you. Great field. I'd like to probe a little bit more on the social media side. You gave a great example about the skepticism in social media and the wave you need to hit against to get it through. Do you have a positive example of social media that actually you can leverage this to spread your recruitment, spread your work? And do you have, in general, any strategies to counter misinformation or bring out your message through social media?
I can start and then jump in if you would like to. That at the moment, we've been focusing on partnering with other groups that are really leading the way. So there's a campaign, Science Up First, that's partnered with the, I'm going to get the acronym wrong. I know that we say POWER, and it's a Pan-Canadian Women's Health Research Organization, but I can't recall exactly the letters or how they support that acronym. And they've been really focusing on misinformation in women's and reproductive health broadly. So we've been working back and forth with them about, like, what do we think the right strategy is. And so I think there are kind of multiple schools of thought, where one school of thought is become an influencer too. And there are some great examples of that in especially from physician leaders who have taken to social media themselves to dispel myths about contraception specifically or other domains within reproductive health. And then other folks that are saying, you know, maybe we need to try to disempower social media as a trusted source of information overall. Through some qualitative work that some colleagues have done, one thing that has come up repeatedly is that especially youth, when they're trying to disentangle information quality online, having trusted sources of information clearly state their affiliation is really important. So for example, bus ads with the Ministry of Health logo on it, to clearly say, this is what's true about contraception, and you can trust it because this is who we are telling you this. It's hard to really measure that. Like, I think since this idea came up within our study, there's been just suddenly a sea of publications about the content on social media and how it is generally inaccurate. Less than 10% has an expert involved in the contraception space. So I think that there needs to be really a multifactorial approach here, where we have some social media influencers that are physicians, researchers, patients, providers that have access to high quality information, while at the same time offering really clear ways to differentiate between good and less trusted information sources.
Excellent.
Do you want to add anything, Victoria?
So we're just at the end of time. If everybody could, again, give thanks to Laura and Victoria for a great presentation.